Hello and welcome to Doc Talk Live. We are here with surgical oncologist Jason Marengo. He's with NorthBay Healthcare, and today we're talking about reconstructing life after breast cancer. Take it away, Dr. Marengo.
How are you? So my name is Dr. Jason Marengo. Thank you so much for joining us today. I'm a fellowship-trained breast cancer surgeon as well as a plastic and reconstructive surgeon. And what I want to talk about today, before taking some of your questions, is the importance of screening mammogram, particularly in the era of COVID. Okay, so one of the things that's really important to understand is that when we look at the data, probably about 1 in 8 women in their lifetime will develop breast cancer. When we look at those risks of developing breast cancer, with each decade of life, that risk increases. At the age of 50, that risk is about 1 in 43. And then that risk at the age of 70 climbs to 1 in 26. So that risk will go even higher with patients who have family histories of breast cancer. The thing we need to remember is that our most effective tool in treating breast cancer is trying to detect it at an early stage. What we know is that when we detect breast cancer at a very early stage, the outcomes are much better and the treatments are much less invasive. And the best tool we have is really screening mammogram. With screening mammogram, we're detecting breast cancers even before they can be felt or even seen in terms of skin or nipple changes, so it's really important. So the question then becomes, where does screening mammogram now fit into the era of now COVID that we're dealing with? You know, early on in this pandemic, early on in the year, when we were all learning much more about COVID and how it's being transmitted, the national cancer organizations felt comfortable with recommending and saying that you could delay your mammogram for a couple of months as we learn more about COVID and how to protect people from that. But unfortunately, what's happened is that for many patients, that couple of months, 2 or 3 months, has turned into 6 months or longer. And again, that screening mammogram is our most effective tool at finding cancer early. So what's happened, over the last, 6 months or so? Well, what's happened is that many of our hospitals, especially here at NorthBay, have really retooled and repurposed and reimagined how to deliver care safely in their hospitals and their clinics. And this is made for a much safer experience at NorthBay. What has this included? What this has included is, number one, social distancing in all of our clinics and in our hospitals, in addition to extensive facility cleaning in between patient encounters, as well as screening both patients and staff as they enter the hospital with temperature checks. Also, mandatory masks for all patients and staff, limiting the number of visitors that are coming into our facilities. And in some cases, in some of our clinics, we've even established drive-up clinics where in some cases we can deliver both care and treatment and screening right in your car. So that certainly has helped limit the number of people that have been in our facilities. So, my appeal to you is that we really should get back to screening mammogram. We have a very safe experience here at NorthBay in both our clinics and our hospitals. We follow, many of the recommendations with our Mayo Clinic affiliates. We have this relationship with Mayo Clinic for second opinions, but also we rely on them heavily in terms of their understanding and their learning in terms of COVID, and have adopted many of their policies too in terms of making your experience here much safer. So again, conditions like COVID will be with us for months or even potentially years. We have really made a very safe experience here for patients in terms of getting their screening and treatments, and we encourage you to please resume screening mammograms. So, are there questions you have?
Let's talk a little bit about reconstructive surgery after breast cancer. Is it done before you have the chemo and radiation or after, and what's the determining factor of when you would do that?
Sure, of course. So breast reconstruction can actually be started at the time of the breast cancer surgery. So whether that be removing an entire breast called a mastectomy, or whether it be removing just a portion of the breast being lumpectomy, we can begin reconstruction to limit the defect at that breast. In the case of patients who are having just a portion of their breast removed called lumpectomy, we know that many of those patients are going to be receiving radiation to further decrease the chance of that cancer coming back. We know that radiating areas of the breast where there have been deficits, defects, meaning portions of breast removed, can exacerbate and worsen that defect. So the time to begin reconstruction for those patients is often at the time of the breast cancer removal. So in patients with appropriate anatomy and excess breast tissue, we can often combine breast lifting and breast reductive techniques to reshape the breast at the time of the breast cancer removal so that we limit the contour change at the time of radiation. In patients who are having their entire breast removed, oftentimes we can begin reconstruction, meaning placing a tissue expander in that area of the loss of the breast to create a pocket in the clinic by expanding that expander with air or fluid, and then eventually, several months later, reconstructing with an implant or using your own tissue. There are also sometimes, in some patients, where it's safe to actually reconstruct immediately where we place the implant at the time of the breast removal.
Okay. And so does reconstruction, does it hurt? Like how
Sure.
long does it take, and
Sure.
and what are the outcomes usually?
Sure. So again, it depends on what sort of surgery is being done. So certainly with reconstructing partial breast defects, whether that involve reshaping the breast with breast lift and breast reductive techniques, or whether that involve using fat grafting techniques where we harvest fat from elsewhere in the body via liposuction and then inject fat into the areas of the defects. Many of those procedures are outpatient procedures where people can leave the same day, or if they do stay in the hospital, it's really just overnight. Some of our other surgeries where we're placing tissue expanders at the time of the breast removal or placing implants, those recoveries are also short, but can sometimes require an overnight stay and can limit the overall activity of a patient in terms of heavy lifting for a couple of weeks. But generally, these are surgeries that can be easily recovered from in a number of days to weeks.
Okay. How does it? Are there different options? Like, is it a breast implant, or how do you do the breast
Exactly.
reconstruction?
So at the time, in the case of breast removal, when we're placing a tissue expander, that allows for us at a later date when the breast is finally being reconstructed to either choose an implant or the patient's own tissue, so that the patient at the time of the breast removal does not necessarily have to commit to using either an implant or their own tissue. They just need to have a sense that they want the breast reconstructed, and at that time we place the tissue expander to create a pocket. Then over the course of a couple of months, with further counseling, we can have further discussions to discuss whether we would at the next stage simply place an implant, which is a shorter surgery and a more direct course to reshaping and creating a breast, or whether they would be interested in a more involved surgery where different blocks of tissue from either their abdomen, possibly, or their back can be used to be brought onto their chest wall to reconstruct a breast at times with no implant. But again, that decision on the part of the patient at the time of their initial breast cancer surgery does not have to be done. They don't have to commit to either using an implant or their own tissue at that time. And I've found that with patients, at the time of their initial cancer surgery, there's a lot that they're worried and thinking about. And oftentimes, all that they really can commit to is obviously the cancer surgery and knowing that they want reconstruction, but can't always commit necessarily to an implant or using their own tissue, and that's okay. There are certainly protocols we have where we can make that decision at a later date.
And does aging affect the reconstruction?
I mean, to some degree it can. I would say that the greater concern, as opposed to aging, are the number of other medical illnesses someone may have. So if someone has significant heart and lung disease, they may not be the best candidates for having breast reconstruction, and it may be important enough that we treat the cancer and not subject them to other surgeries. I would say, rather than someone's age, I would say one of the more significant issues in terms of breast reconstruction is really tobacco use and smoking. What we've found in the literature from a plastic surgery standpoint is that whenever nicotine is used, it causes the vessels to constrict down and affects blood supply. So patients who are using tobacco are much more likely to have complications, meaning skin loss or wounds, with their initial cancer surgeries and attempts at reconstruction. So I would say that, more important than age, quite frankly, is tobacco use.
Okay. So is most of this kind of surgery, is it covered by insurance? Or
Yeah, it is. I would say that, breast reconstruction following either breast removal or partial breast removal is covered by law, by federal law. I would say that some insurance companies sometimes have a concern over using fat grafting. It certainly involves liposuction, harvest of fat from elsewhere in the body, processing that fat and injecting it to recontour the breast, and that's certainly a tried and true way that's seen in a lot of our plastic surgery literature as improving breast contour and to some degree improving also changes that occur at the skin from radiation. But there are some insurance companies that can sometimes challenge the use of that, and if they deny the use of that in our pre-planning processes, we always try to appeal it, but it doesn't always allow us to do it. But I would say in most patients that is an option.
typically, how long is recovery following the surgery?
Yeah, so recovery from breast cancer really, again, depends on the type of surgery that's done. I would say, from the standpoint of a breast reductive approach, meaning rearranging breast tissue at the time of a tumor removal, that sort of recovery it looks like you're having drains in place for a couple of days. You may be on a narcotic pain medication for a couple of days. From there, I think you're transitioning over to really more of a Tylenol, Advil pain medication, able to do administrative work within probably a week or so, and then unlimited activities at probably by 3 weeks. If you're having a more complicated breast reconstruction where blocks of tissue are taken potentially from your abdomen to fully reconstruct the breast, that's a longer recovery. That looks more like being in the hospital for probably maybe 3 or 4 days, having drains in place for a couple of weeks, and then very likely getting back to most of your activities within 3 to 4 weeks.
So will the reconstructed breast match the other breast? Are
Sure.
you going to be able to tell the difference? And
Yeah, so the goal with breast cancer reconstruction really initially is symmetry in clothing. So trying to create the projection of a breast, the contour of a breast that allows for symmetry in clothing. There's usually a difference between the two breasts, and there usually is a difference anyway. But particularly if someone has received radiation, particularly if someone has an implant just on one breast, that can create a larger difference between the two breasts. Now, when there is a significant difference between the two breasts, and then the unoperated breast is either more kind of droopy or ptotic or is larger, there are surgeries that can be done to the opposite breast that had not had the cancer to reshape it to make it more similar, that again are covered by insurance.
okay. And so will the breast have, is the after effect, will you be able to, will it have feeling to the touch, or does
Sure.
it cause any kind of nerve damage or anything that you can't feel?
Again, it certainly depends. If a partial breast removal is done, and in a reshaping procedure done through a breast lift or breast reductive technique, then oftentimes there is sensation intact at the nipple areola area. If a complete mastectomy is done, meaning when the entire breast is removed, even if it's a nipple sparing procedure, most often there is not much sensation at the nipple areola area. There's some sense of pressure, sensation of pressure at the area of the skin in terms of touch, but in terms of that fine sensation at the nipple and the skin area at the breast where the breast has been removed, typically there's not that sort of sensation.
I know some women have gone ahead and done a preemptive mastectomy, one breast is being removed. What's your advice or your thoughts on getting both removed?
Sure. So, that's a question that comes up often in patients who are having a mastectomy and a breast removal. Really what I advise to the patient is that the removal of that opposite breast really needs to be tied to what the risk of breast cancer is overall. So in our patient population that's at very high risk, where there's been a genetic change that they were born with, for instance, the BRCA1 or 2 gene mutation that has placed this patient at maybe an 80% lifetime breast cancer risk, then it's not that uncommon that we may be discussing removing the other breast that is otherwise healthy. When the risk is much lower, and this is more thought to be a sporadic breast cancer at the opposite breast, then ultimately, the way that I feel about it is that it is the patient's choice, but that they need to understand that it is more surgery, and that whatever surgery there was at the other breast with the cancer in terms of the breast removal and the reconstruction, that's being done at the opposite breast, so you're increasing the overall risk of complications to some degree and the overall recovery that's required. But generally, people still do well in terms of recovery, but I would say it's a very personal decision, and the patient really needs to understand what the level of risk is and what the goals are in terms of removing that opposite breast.
Can you talk a little bit about what's special about or different about how you do reconstruction compared to other
No, exactly.
healthcare
Well, I
people?
think that some of what we do that's different is that we take that reconstructive mindset to every breast procedure that we perform. Whether that is a partial breast removal, whether it's a breast biopsy, or whether it's complete breast removal, the classic, guidelines and tenets of breast augmentation and breast enhancement and cosmetic aesthetic breast surgery, I apply to every breast procedure I perform. And there are classic, measurements that are done. There are classic relationships that exist between the position of the nipple, the inframammary fold, the placement of the nipple areola in terms of the breast contour, that we take every effort to preserve. And I think, performing that breast removal with also the mindset and the understanding of a plastic surgeon, I think allows us to burn less bridges, quite frankly, and to not unnecessarily damage the existing dimensions of what's left of the contour of the breast, and allows us to really have many more options when it comes to finally reconstructing the breast.
And can you also talk about how NorthBay Cancer Center works collaboratively among the oncologists?
No, exactly. So, what's unique to breast cancer is that multidisciplinary collaborative approach is key. And the reason why is because whenever I talk to my patients about the treatment of breast cancer, I often talk about the multiple treatments that are often combined, and that's surgery, and that's medication, and that's sometimes radiation. And what's really important is that those elements need to be speaking to each other. And here at NorthBay, we absolutely do. I mean, there is really not a patient that will have their breast cancer surgery done before they see a surgical oncologist, a plastic surgeon, and a medical oncologist. We have weekly tumor boards where we discuss every patient's care prior to treatment, so that everyone has a voice, including our medical oncologists, surgical oncologists, reconstructive surgeons, pathologists, radiologists, radiation oncologists. And that's really key, that multidisciplinary approach, that communication. In addition to all that, what NorthBay has done to facilitate that communication beyond our weekly tumor boards is that we're all in the same building. Our radiation oncologists and radiologists are on the first floor. Our medical oncologists, surgical oncologists, as well as our reconstructive surgeons are on the third floor. And it's not uncommon that I'm going downstairs to talk to our radiologists to review imaging, or that the radiation oncologists are coming upstairs to discuss patient care. So that collaborative approach, I think, is key, and is the reason why we have such fantastic outcomes.
So as a plastic surgeon, other than breast reconstruction, are there other type surgeries that you do, and is there somewhere we can find more information?
Absolutely. So my plastic surgery practice really encompasses a lot of plastic surgery, whether that's reconstruction from cancer surgery, whether it's reconstruction from trauma, or whether it's cosmetic aesthetic surgery. So we have a definite focus in terms of breast enhancement and revisional breast surgery, as well as truncal surgery, whether that be recontouring the abdomen, the flanks, or also, of course, post-bariatric surgery, where there have been changes, in the arms, torso, and lower extremities, based on patients' changes in weight that have occurred due to massive weight loss. So we really have a broad spectrum of reconstructive and cosmetic aesthetic surgery that we provide here at NorthBay, and we look forward to seeing you in our clinic.
Now, you talked about NorthBay having cancer boards, but we also are a part of the Mayo Clinic Care Network. Can you talk about what that means for cancer patients?
Absolutely. I think it's an easier way for our patients to get second opinions, as we say, close to home. So, when patients come in to see us and we are helping to design a plan of care, including surgery and possibly some medications and plus or minus radiation, if a patient has some degree of concern and wants a second opinion as to any element of that care, we have a process where we can involve the Mayo Clinic. Now, of course, the Mayo Clinic is not able to examine you, but they are able to review your slides, they're able to review your imaging, and when we have these focused clinical questions in terms of different types of treatments, they can weigh in and really have provided a lot of great advice and additional input that I think have really helped our patients feel comfortable with their decisions.
And they know a lot of clinical trials and things that we might not be aware of.
Exactly. We have a very robust clinical trial program that's here, but certainly they've been a benefit in terms of further advisement from a clinical trial standpoint. Absolutely.
Is there anything else you want people to know about reconstructive surgery, the cancer care we provide, and if they what do they do if they think I need to see a doctor?
Exactly. So a couple things. What I'll say is the power of the care we provide here is that it's so multidisciplinary. We involve all the aspects of your cancer care that are so important in terms of making sure that you are receiving the most advanced care that has been found in the literature to have fantastic outcomes. And it's really only when those different parts of your care are speaking to each other and planning together that you receive the maximum benefit in terms of your outcome. If I have one piece of advice, it's please, 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 let's not lose our focus in terms of some of our preventative care during this era of COVID. We really have a very safe facility that's here. There's a tremendous amount of investment NorthBay has made to make this a very safe facility. And I think that we really need to make sure that we don't lose sight of some of those tools that we have that have really improved our outcomes from a breast cancer standpoint. And absolutely one of those is Mammogram, for sure.
All right, well, we're about out of time, but I want to invite everyone to join us right here on Facebook tomorrow when urologist Dr. Kara will be talking about robotics and robotic surgery in urology at 4:30 here on Facebook. Thank you, Dr. Marengo, for taking time. We know your schedule is busy and we really appreciate it.
I appreciate the time. Thank you so much.